A real warm welcome to this Fuse Knowledge Exchange Conference Taster Session. My name is Ashley Adamson, and it's my privilege to be the director of Fuse and to welcome you all to this event today. It's been a long time in the making, and there's a lot of people put a great deal of work into keeping this on the road, and obviously, like many things, has hugely been impacted by the pandemic. But I think the programme that we have ahead of us today actually demonstrates some of the advantages of the fact that we've now all got used to having conferences and conversations and meetings online and in these forums. So we have a packed programme for you today, and we're going to go and look at those in a minute. But before we get into that, I just want to remind everybody of the hashtag, and please do tweet as we go through, and do of course also use the chat function. It's all enabled, so please do use that chat function to reach out to each other and also to everybody at the meeting. So we're going to have a world tour almost today, and I'm just going to ask Peter to go on to the next slide, please, while we have a look at the programme. So we're going to US, to Canada, to the Netherlands, and also, of course, to the northeast of England. And those of you who are familiar with this series of conferences, the Fuse Knowledge Exchange conferences, will be aware that the last time we had this meeting, we were all in the wonderful city of Vancouver, and have had a wonderful meeting there. And it feels like a long time ago, but it certainly was a real pleasure to be hosted by our colleagues in Canada, some of whom are involved in the organisation of this taster session, but also the conference that we are trailing and will tell you more about, which we very much hope will take place in person next year. So the programme is as you see it, and I'll introduce people as we go through. We are planning to have a comfort break at 5 to 5, just a brief comfort break, and then there will also be a panel discussion with all of the speakers from 5:30 onwards, when we will close at 6 p.m. Obviously, these times are all UK times, and it will be very different depending on where in the world you're at. Okay, so perhaps if you could just go on to the next slide for now, Peter, please. So I think most people have done this, so make sure that your microphone is muted and remains so, unless when we get to the panel discussion you want to speak, or if the speakers invite questions. And again, most people, I think, just to stop your own video, and it does help with that. But when we come to the discussion sessions and so forth, we will ask everybody to turn on the cameras, and of course the speakers will have their cameras on as we're talking. Some of our presentations are pre-recorded, but the speakers are all present. During the presentation, use the chat box, as I've already said, and we'll manage those and put some questions to our speakers. And I think the next two items, bullet points on there, are as we would expect, but please, just to draw your attention to those final two bullet points. Okay, so Peter, next slide, please. So I think this is just for those that aren't familiar with Fuse. We're based in the northeast of England. We are a collaboration of the 5 northeastern universities, which are listed along the bottom there: Durham, Newcastle, Northumbria, Teesside and Sunderland. And we are a centre of excellence in public health research, particularly in translational research in public health, and obviously a virtual centre across that northeast geography, with that USP of translational research. We very much work in partnership with policymakers and practitioners, enabling research findings to be understood and applied to public health in issues. And we're a member of the NIHR School for Public Health Research, and I'm delighted to see some of my colleagues from other members of the school in this meeting today. And the NIHR School for Public Health Research has just had the good news of being renewed from 2022 through to 2027. So that's exciting news on that renewal. So I think now we are going to go into our first presentation, and this is by Dr. Peter Lurie, who's the president of the Centre for Science and Public Health Interest in Washington, and previously was the Associate Commissioner of Public Health Strategy and Analysis at the FDA. And I think the speakers that we have this afternoon have got that real mix between academics, policymakers, and people who translate that research. So we very much look forward to hearing all of the presentations, and that first one from Dr. Peter Lurie. So Peter, whenever you're ready, if we could play that pre-record, please. Here we go.
Here to make a presentation on some ongoing research we've been conducting on COVID vaccine misinformation in traditional media. So I'll start off by describing our methods. We used a company named Cision's next-gen communications cloud platform. And what that does is it aggregates global online news media from traditional media, blogs, podcasts, and so forth. It's an enormous database, which we plumbed for the period between July 27th, 2020, which was when the first vaccines went into trials, and January 19th of this year. We restricted ourselves to English language and to the 100 outlets that had the largest reach for COVID-19 vaccine articles. And reach is defined as the number of unique visitors to an online publication in a given month, as measured from desktop computers. And I'll get back to the concept of reach later in the presentation, but we restricted ourselves to these 100 largest outlets in that respect. The primary research tool was a Boolean search string, and I'll show you in a moment how we put that together. But that Boolean search string had pretty high sensitivity in that we had 50 known misinformation articles as a kind of test, and the Boolean search string was able to identify 49 of those for a 98% sensitivity rate. This shows you how we put the Boolean string together. There were 6 basic themes: development, safety, conspiracy, political and financial, alternatives, and morality and ethics. And within these various themes, there were sub-themes, and there were various numbers of sub-themes within themes. So development had 3, which were developed too quickly, or not tested properly, or mandates. There were 6 like that within the safety, and so forth and so on. And they each have these colors that I use consistently throughout this presentation. So the next-gen platform has about 7 million sources in it. And of those, using our Boolean search string, we were able to identify in the study period 8.4 million articles on COVID-19 vaccines. We restricted ourselves, as I noted, to the 100 outlets with the greatest reach, and that produced 479,000 articles. We then had this misinformation string that I just described to you. And so within the articles on COVID vaccines, 17,000 of them were identified by our string as having vaccine misinformation. Now, once we identified an article as having misinformation, as you've already seen, they were coded for theme and sub-theme. But we also took a random 500 of these 17,700 and looked at those closely individually, reading them and actually having a couple of coders look at most of them. And these were coded not only for themes and sub-themes, as were the full data set electronically, but these were manually also coded for what we called primary misinformation, which is the misinformation that most people think about as misinformation, stuff that really is pushing something that's inaccurate. Fact checking, which is if somebody is trying to establish the veracity of something. So perhaps looking into whether something is in fact misinformation. And then there's a third category that I'll get to in a bit, which is refers to misinformation, which is a situation in which misinformation is talked about, but is neither the purpose, the purpose is not to disseminate it per se, nor to fact check it, but it is referred to. So that's the basic approach, and now we can turn to some of the results. So looking at the Boolean string again, we were the largest numbers of misinformation themes. Remember, there were 6 themes by volume. So the numbers of articles were safety, which in the study period had close to 10,000 articles. Development, about 6,500, followed by the theme of conspiracies, political, financial, morality and ethics, and alternative treatments. This slide, we look at the same data, but break up each of the themes into their sub-themes. And so these are all the sub-themes. So in the development category, the most common was developed too quickly, almost 4,000 articles. These red are all safety themes. So there's a few other safety themes. The most common ones, general side effects, chemicals in the vaccine, or that the vaccine itself causes COVID. And then the 5th most common sub-theme is again a development sub-theme, which is not tested properly. And then you see a variety of other of the sub-themes all occurring considerably less frequently, including things that might be familiar to you, like cause autism, population control, miracle cures, election conspiracies, fetal remains, that kind of thing. So on the next slide, you can see the volume of COVID-19 vaccine articles. So this is not with misinformation. This is just of the 479,000 articles in those 100 outlets with the greatest reach. This is the number of articles about COVID vaccines. And you can see that it's more or less stable for this period through the beginning of November. And then in November, suddenly there's this big takeoff in the number of articles about vaccines, which I suppose is unsurprising because that's when they started to be considered for emergency use authorization. This shows the number of those articles that had misinformation according to the Boolean string in the same period. And you can see that again, it's more or less stable up until a similar period, and then the misinformation starts to become more common at about the time that articles start to be more common, which poses the question, is the percentage of vaccine misinformation articles going up in the same period? And if you look at that, you see that that actually isn't the case. Although there are more articles in this period, the rate of misinformation is actually higher in this earlier period here in August. So this shows the themes, the 6 themes in our Boolean string, and the trends in those over the study period. And you can see, as remember from before, that safety and development, red and blue, are the most common of the sub-themes. Most of the less common sub-themes remain pretty stable all the way through the study period, but you see somewhat more in the development category here in September when the trials were right in the middle of taking place. And then you see a big peak over here in red in the safety as we come around the period after approval of the first products. So I said that among the 17 or so thousand articles that had that were flagged as having vaccine misinformation, we took a close read at a subset of them, and those were 500 that were randomly selected. And those were read, as I say, closely and coded in a number of different ways. So the first way was just to establish if there really was misinformation at all in those 500. And somewhat disappointingly, we found that in a fair number of cases that was not the case. So we couldn't find 13% of articles 32% turned out to really be unrelated to misinformation. Oftentimes that had to do with an advertising bar down the side of the article. So really only 55% of the 500, and perhaps by implication 55% of all of the misinformation articles actually have misinformation. Those, as I said, were coded for their different themes, and the most common ones, as we saw overall in the Boolean string, were development, 55%, and safety, 45%. Conspiracy was fairly common as well. Everything else was under 20%. So in the next slide, we look at these 277, right? So among the 500 that are randomly selected, 277 have misinformation. Now we're going to look at the 277 in greater detail. And for those 277, we learn that fact-checking is actually the largest category at 63%, followed by this refers to misinformation category at 31%, and it's only 6% of these 277 articles that are actually primary misinformation, what people would think of as, you know, the truest form, I suppose, of misinformation. And that only amounts, as I say, to 15 articles. 9 of them are about development, 6 of them are about safety, 6 of them are political, financial as well. Obviously, some have more than one theme within them. So here we look at the 3 categories: fact-checking, refers to misinformation, and primary misinformation over the course of the study. You see there's few primary misinformation articles. You can't say much about them going up or down. The main thing you can see from this is that there's an increase in December in fact-checking articles, which I think is an interesting, apparently developing trend. So we wanted to estimate the percentage of articles that were actually primary misinformation. So I said that we had 479,000 articles that were on COVID vaccines, and that our Boolean string identified 3.7% of those as apparently containing misinformation. However, when we looked at a random subset of 500 of these 479, of this 3.7%, only 3%, those 15 articles, turned out to contain primary misinformation. And so if you multiply these together, 3.7 by 3%, that gives you a 0.1% overall rate of primary misinformation among all of the articles that are about COVID-19 vaccines. And here are the confidence intervals, but this is your point estimate. So I'll just close off by touching on the reach of these vaccine articles. And I mentioned before how that was defined. It's defined by the reach of the outlet itself, right? Not of the article itself, and we don't really know if the article was itself read. We just know if it reaches the desktop computer of a given user in the system. And you can see the trends over time in terms of reach, which have, you know, some similarities to be sure with the numbers of articles. But it only takes 1 or 2 articles with a lot of reach to get very, very high numbers of people being reached. You know, here in the hundreds of millions of people just in a single week for, in this case, safety and development. Another peak, just a few small number of articles again, just a few weeks later. And here, again, the peaks are mostly safety and development, although there's a late breaking trend in increased reach for articles that are conspiracies. Overall, the safety and development articles represented 69% of all reach. Here are the data, again by reach, this time arrayed by fact-checking, refers to misinformation, and primary misinformation. And these mirror data that you've seen for volume of articles in previous slides. Again, fact-checking is the largest category, has a couple of peaks corresponding to some the safety and development peaks from earlier. And then you see this increase in fact-checking late in the study period. Overall, 70% of reach is fact-checking, and the US, which had about 55% of the volume of articles, has about 80% of the reach. So the limitations of our study are that most of the early portion of this presentation is based on an automated approach to data analysis using a Boolean string. We had a false negative rate that was low, but the close read subset shows that the false positive rate was really, not small at all. The close read subset is subjective, although we did use multiple coders. We limited ourselves to the top 100 outlets and also only to English language resources. We've talked a little bit about the reach metric and how even if it reaches your desktop, it doesn't mean that you read it. And then there is the rarity of primary misinformation, just 15 articles in our close read subset, and that precludes certain cross-tabulations that would certainly be interesting. So overall, we looked at a wide, that we conclude that there was wide traditional media coverage of COVID-19 vaccines, but that only 0.1% contained primary misinformation. Despite that, though, the reach of particular articles or of these 0.1% can be vast. The primary focus of articles and of primary misinformation articles was on safety and development. There's a recent growth in fact-checking, and all of this has the potential to contribute to vaccine hesitancy, particularly if the articles are widely shared. Finally, articles that refer to misinformation without refuting it can influence the conversation themselves. Here are my collaborators who join me from the Decision Company, which has the platform we used, the Alliance for Science at Cornell University, and Vaccinate Your Family, an advocacy group in Washington, D.C. Well, thank you for listening to my talk, and I look forward to the conversation to come. Thank you.
Thank you, and I think that sets the scene against the rest of the presentations, and obviously the focus on what we're hearing in terms of misinformation and the impact of that, which we're certainly seeing in some of the vaccine reticence that we're seeing amongst all of our populations. So we're now moving on to going to North America, further North America and into Canada. And we have two presenters, and Maureen Dobson and Leanne Zerdera. I may have pronounced that wrong, and I'm going to ask her to correct me when she speaks. Maureen is the Scientific Director at the National Collaborating Centre for Methods and Tools in Canada and Director for Health Evidence. And Leanne is at the Public Health Agency in Canada as a Senior Research Scientist with Evidence Synthesis and Knowledge in the Knowledge Translation Unit in Health Promotion and Chronic Disease in the Chronic Disease Branch of the Public Health Agency of Canada. So you're both very welcome. Maureen is going to talk to us about rapid reviews in response to public health decision makers' needs, methods and dissemination. And I think we're then going to go straight on to the presentation from Leanne. I should have said that our previous speaker, Peter, will be joining us in person from 5 o'clock and will join the panel discussion. So please get your questions ready for Peter as well as the other speakers. Okay, Maureen, thank you very much. You're most welcome. Over to you.
Great, thank you so much. My pleasure to be here, and I'm actually in my office at McMaster University today. This is new for us in Ontario and Canada, slowly starting to try to get back into our offices, and I just would like to let you know that McMaster sits on the traditional territories of the Mississauga and Haudenosaunee nations and within the lands protected by the Dish with One Spoon Wampum Agreement. Next slide, please. So I'm going to give you a whirlwind tour of what our center has been doing since about April of 2020. Normally our center is funded, our center is funded by the Public Health Agency of Canada. And we normally, our mandate is to help support, develop knowledge, skill, and capacity to use best available evidence in public health decision making. But we really, during COVID, have shifted significantly our work to synthesizing the evidence to help support decision-making around public health measures in Canada. So that's what I'll talk to you about today. So very early on in the pandemic, we started receiving requests from federal, provincial, territorial, local organizations, and other international organizations for help in synthesizing the public health evidence related to COVID. And so this has been very much a work in progress in terms of taking what we already knew about rapid evidence syntheses and evolving those methods as the evidence ecosystem and COVID evolved over the last 19 months or so. For us, we developed a weekly team meeting, and at that team meeting, we assessed our progress on current reviews that we were working on, and we also assessed our capacity to start new reviews as we were receiving questions on a weekly basis. And what helped us prioritize what reviews we would look at, because actually the number of requests coming in oftentimes exceeded our capacity to work on them. So in terms of prioritizing, we tried very hard to avoid duplication. And so we looked to another group in Canada that's called COVID-End that was also helping organize rapid reviews. So we looked to see within that very large network of about 40 to 50 organizations, if anyone else was working on that topic. We also assessed the urgency and relevance of the question to the Canadian context. We assessed our own content expertise to address the question. And we also looked to see if there was any useful evidence that would help inform that question. Next slide, please. And we started with formulating the question, and some of you may be familiar with the PICO, or that's for quantitative questions, or PS acronym, which really PICO stands for the Population, Intervention, Comparison, and Outcome, as you can see on the table on the right. We collaborated with the requester, so this is really, really important to make sure that we understood the question and to also try to refine that question as much as possible so that there was a very focused question so that we would be able to answer that question as quickly as possible. And this, the step also allowed us at the outset to really start thinking about what the inclusion and exclusion criteria would be. And as you can see here, this formulating the question really drove, this is one example of our reviews of the types of inclusion and exclusion criteria from the outset, so that when we moved into screening, we had a good sense of what we were looking for. Next slide. And then we developed our search strategy, and this is something that very much has evolved as various resources related to COVID were created, as well others that we learned over time were less useful for searching, but generally we, for our searches, we were predominantly focusing on the many COVID-19 databases that were created. We limited our search to English language. We included peer-reviewed sources as well as preprints. As many of you know, up to at least 40% of the evidence on COVID, particularly in the first 3 to 6 months, were in the preprint. It might still be there. I haven't looked at that number recently. And then depending on the question, we also look to the gray literature and even jurisdictional data, depending on the issue. And then always looking for syntheses first before single studies. So again, trying not to duplicate. So if there were syntheses that had already been done, then we would look to those first. Next slide. In terms of screening, so of course, when you're doing rapid evidence syntheses, and we were trying to complete these reviews in 5 days in the first, let's say, 8 months of COVID, they're now somewhere between 10 to 15 days. So some of the trade-offs was that we used a single reviewer to look at title and abstracts during the screening. We then exported those results to a software called Distiller SR, and we were able to use a function there called DAISY that learns as you go by finding the relevant reviews. So it will actually put to the top of your result set those articles that appear to be most relevant, and everything later in the list are much less likely. That allowed us to be able to start moving to other parts of the review because we had a good good sense that we had found most of those articles, and as we did other parts of the review, someone could keep looking through the rest of that list that was less likely to have anything relevant. And then some of the sources we had to do manual screening, and we would track those results in Excel. And then we also used a single reviewer for full text screening, and then this was double checked when we were writing our summaries. Next slide. When we then move on to data extraction, so we have created a table, as you can see an example here, and some of the information in addition to where we, like the title, author, where that paper came from. We extracted information on the study design, the population, the setting. That bigger column there is our summary of findings for that particular article. The quality rating in terms of its methodological quality, and then any other information that was relevant to the particular topic. Next slide. We also did critical appraisal of almost all study designs. There are a few exceptions. For example, we did a few reviews that included modeling studies. And there wasn't an appropriate tool that we could use for that. And there were a few other lab-based types of study designs that don't lend themselves well, or there currently isn't a critical appraisal tool that we found. So we didn't critically appraise those, but generally most studies were critically appraised. These were completed by one reviewer and verified by a second, and any conflicts were resolved through discussion and or the review lead as needed. We've used a variety of tools, for example, the AmStar 1 for systematic reviews, Agree 2 for guidelines, and we've also used heavily the Joanna Briggs Institute checklist for all other designs, and then we rate all studies as strong, moderate, or low quality. Next slide. Not at the very beginning, but after about 3 or 4 months of doing rapid reviews, we also then started applying grade to the so that we could provide an overall assessment of the certainty of the body of evidence. And we felt that this was really, really important to do because particularly really early on in COVID, there were many designs that lend themselves to high risk of bias, even though on the critical appraisal, they may have been very well done for that type of design. So when we are only commenting on the quality based on the critical appraisal, we were saying, you know, these were well done studies, but it wasn't really getting at the overall certainty of the evidence. So we have been applying grade, and we list here the 8 domains that are being used to determine whether or not the certainty is very low, low, moderate, and strong. Next slide. So, and the final product, I'm just gonna, the next few slides will just go over that, but very interesting in terms of what was really, really important here. It was our interaction with our decision makers very early on, and particularly at the federal level. They were very clear about what they didn't want. So they didn't want, you know, many, many pages of information to read through. They wanted to be able to get to basically what are the key points that we need to know that come from this synthesis of the body of evidence. So that really changed what the knowledge product looked like. And you can see the front page here of the products. Very, you know, up front, what was the question? We then have an executive summary, and I'll show you that in a moment. We talk a little bit about the methods, and that's usually, you know, a paragraph with a link to more methods if someone wanted to know more. And then the bulk of the information was in results tables, but there's very little actual written text. And if you go to the next slide, I'll just show you a little bit more about that executive summary. So there would be 1 to 2 paragraphs which really set the context and the background of what the issue is, along with what the question is. Key points. So depending on what was covered in the evidence, 3 to 5 main things that are all linked to the grade assessment. and then followed by an overview of the evidence as well as where are the knowledge gaps. So what still needs to be answered after the synthesis. And when we started updating some of these reviews, we actually would include a paragraph about what has changed since the previous review. And in this example, you can see that's the first bullet point that you see there in the maroon color. Next slide. We've also, once we started applying grade, we include summary of findings. So this is an example of what a quantitative evidence synthesis would look like. So when we were looking at studies that had quantitative data, and per outcome looking at study design, the number of studies and the overall certainty, as well as our reasons for upgrading or downgrading provided in a legend. And then next slide. This is an example of what it would look like when we assess qualitative literature using the CERQUAL grade assessment tool. And again, key finding, study design, number of studies, the certainty, as well as an explanation for the grade assessment. And next slide, please. And I'll just briefly tell you in terms of dissemination, this has been actually really tricky to do because decision makers, of course, are extremely busy. So how do you make sure that the folks that need to know about these reviews are aware of them, knowing that they could be out of date, you know, in days? We created a new page on our website where we could house all of the reviews. Up to, as of June of this year, we have completed 65 new reviews or updates. And then we've used a variety of ways to disseminate. So we post them to the website. There are email notifications, so one can subscribe to be notified when we post anything new to that page. And we also had a targeted email list of senior decision makers that we specifically sent these to. We were very active on social media, including them in our monthly newsletter, as well worked closely with McMaster's Communication, which led to many interviews with the media as well. Next slide. And then finally, just around impact, it's also difficult, challenging to assess what impact have we had with these rapid reviews. But generally, some of the metrics, we know that the page, our rapid review pages have been viewed over 35,000 times. We've received questions from folks such at WHO, Public Health Ontario. We've also collaborated with other national entities, for example, Public Health England, on some reviews. We have email subscribers from almost every province and territory in Canada, and we know our reviews are being indexed in other databases, and we can see here, we know they've been accessed by folks in over 160 countries. Next slide. And I'll pass it now on over to Leanne.
Thank you, Maureen. It was a great overview. And welcome everybody to this presentation. My name is Leanne Itzerda, and I am a senior research scientist at the Public Health Agency of Canada. I work with the Evidence Synthesis and Knowledge Translation team, and we're a team of 8 research scientists with expertise in systematic reviews and guideline development. The mandate of our team is to develop high-quality systematic reviews to inform decision-making, and we follow rigorous methodology to include the Cochrane guidelines as well as the grade guidelines. We are a newly created team. We were only created in December of 2020, and we were created in order to develop systematic reviews on priority topics related to the unintended consequences of COVID-19. You can put the next slide, please. In the 9 months that our team has been around within the Health Promotion and Chronic Disease Prevention branch, we have worked on a variety of topics related to COVID-19, but we have already demonstrated the value of our team. And so the intent is that our team will continue to function once the COVID pandemic is over. And we are already starting to work on other systematic reviews not related to COVID. Next slide, please. A few examples of the topic areas we work in is the post-COVID-19 condition, also known as long COVID, mental health, family violence, prevalence of household food insecurity during COVID, and then interventions to reduce household food insecurity. We have 23 topics that are on our priority list, and we're slowly working through each of those topics over the course of this year and next year. Sometimes we conduct systematic reviews internally using the expertise of our team, although we always have a subject matter expert on our team, and we have access to methodologists from academia and other organizations. But sometimes the bulk of the review is conducted internally. Sometimes we contract the review out. So for example, the mental health systematic review, we contracted out to researchers at McGill University because we did not have time availability. We're only 8 researchers with 23 priority topics, and we also lacked expertise in that area. So it was felt better for that topic to contract it out. And sometimes we do a hybrid of internal and external. And that is what we did with Maureen's group, the National Collaborating Center for Methods and Tools. And that was regarding our review on the prevalence of household food insecurity during the pandemic. So I'll tell you a little bit more about that. Next slide, please. So one of the reviews that I was tasked to lead is on the prevalence of household food insecurity during the pandemic. And as a first step in the process, we conducted a scan of the literature, as we always do. And we found that the National Collaborating Center for Methods and Tools, NCCMT, which is Maureen's group, had already conducted a rapid review on this topic in December of 2020. We contacted them to find out more about their review, and they kindly offered to update the review for us. And so in May into June of 2021, they updated the review, and it was updated within a matter of weeks, which is much quicker than we would have been able to do that internally. We used the results of that review to inform the strategic direction of the Chief Public Health Officer, and the results will also be included within the Chief Public Health Officer's annual report. And so we did use them quite substantially. We decided that we wanted to do a more in-depth analysis specifically on the subgroups that were affected by household food insecurity. And so we took over the review and didn't update it, but sort of went a bit more in-depth into the data with the team at NCCMT. And we have submitted for publication this review that came out of it, the full paper that came out of it. And we've also used those subgroup analyses and the reviews internally to inform a number of decision-making processes as we move forward. Next slide, please. And so a few of my reflections, we are very interested in working with academics and other knowledge producers, as within government, we don't have the resources. I think research within government is there, but it's only maybe within the last few years being valorized as it should be. And we're often lacking, because we cover such a broad variety of topics, we're often lacking in specific content methodology on the topics, content expertise on the topics, and also occasionally need to contract out for methodological expertise. And I'm happy to say that most organizations that we've contacted for support in either content or methods have been very quick to respond and are interested in working with us. For example, NCCMT, the JBI Center, the GRADE working groups, and various academics across the Canadian contexts, both within universities and outside universities, have been very supportive and helpful in working with us. And so just in closing, I think that government can be slow and often lacks in scientific expertise and the appreciation for science, although that is changing, I think, because of the pandemic. But if the political will is there, we generally have the resources to answer priority questions. But what we find difficult is connecting scientists within government with those outside of government. So a network or community or some way of connecting with those who would be able to help us with our work internally to government. Thank you. I look forward to the discussion later and any questions you might have.
Okay, thank you very much, Maureen and Leanne. I think there's an excellent example of partnership and also demonstrating how timely synthesis of evidence to be available for the decision makers when they need it. and also in formats that are accessible. So really fantastic presentation, and the website information is there on that slide, and perhaps we can ask one of the conference team to post it in the chat too, so that people can access that as we move on. Okay, so we're going to move on now, and this is my great pleasure to bring you now from North America back to the UK, and first of all to welcome my colleague Dr. Peter van der Graaf, who's Associate Professor at Teesside University and the Ask Fuse Manager for Infuse, and also Mia Molanya, who is an Analytical Programme Manager at Public Health England, and they're going to tell us about C-Works. Want it, know it, share it. So we look forward to hearing your presentation, Peter and Maya.
Thank you, Ashley. Mia will start first, and then I will take over the baton. So Mia, the floor is yours.
Thank you very much. So along the same lines, we were talking about partnership. C-Works is also about partnership and collaboration. So thank you very much for inviting me along. I'm going to give a short introduction to what C-Works is, and I'm a program manager, like mentioned, in Public Health England, but I'm based in the North East and Yorkshire region. And analyst by background, I've always had an interest in social determinants of health and health inequalities. So with my relatively new role from March, being part of C-Works has been great, with a specific focus on the wider impacts of COVID and the indirect consequences. So thank you. So on top of the direct consequences of COVID in hospitalizations and deaths, the indirect consequences obviously also been immense. And that was clear very early on, and already in March 2020, people across the health and care system in our region came together to raise concerns around the potential impacts on health and well-being beyond the rising coronavirus cases, and as a result of the necessary actions to be taken to deal with the pandemic. So the group was concerned about the consequences like disruption to healthcare, screening, increasing health inequalities potentially, and economy and employment, all those wider determinants linked to our health and well-being. And what was mentioned already in the previous presentations, negative effects on mental health, and the list unfortunately goes on. So C-Works was launched to help connect people, ultimately to help identify and address emerging health needs in the context of the pandemic. And if I can have the next slide, please. So with a list of fairly ambitious aims, broadly speaking, the key aim is simply to bring people and organizations together in the region. People are working on similar issues emerging from the pandemic. And as long as I worked in public health, a number of years I care not to specify, we've talked about the problem of working in silos, but one of the consequences of the pandemic is that it's really pushed us out of those silos, and I've worked together with more people and more organizations than ever before, really. So the aim of C-Works is to facilitate sharing, provide a curated resource, which we have an online platform now, as well as online events and a regular steering group with the representations across organizations from public health, NHS, National Health Service, and academia, of course, voluntary sector, and so on. So we also have a steering group, events, platform. They're all there in the service of that collaboration, potentially highlighting gaps, but also maximizing the value of what different organizations are already doing, instead of duplicating of what is already being done. And we deal with complex problems, and only a system-wide response can be effective to deal with those problems. Academic partners, including Fuse, are imperative key. And the impacts of COVID are likely to ripple on years to come. And during the recovery, further collaboration and sharing learning is important. There's no way we're going to be eased back into those silos. And CWorks also needs to be adaptable, respond to emerging issues, and be agile to the needs. Things are moving on very fast. So can I have the next slide, please? This is an example how it kind of works in practice. The more tangible example of a question from our regional director, Professor Peter Kelly, post on child and adolescent mental health, and the plethora of answers to providing evidence, as well as signposting to other regional networks, people who work in child and health and well-being, as well as national evidence from emerging research. And these questions are also then discussed in the wider steering group. And if I can have the next slide, please. And this is just for information. So we have online events like one at present, another way of sharing knowledge and plans across the patch. And you can see the topics, recent topics and the range. And we were very pleased to have Dr. Laura Basterfield via Fuse to present her research as part of the impact on childhood obesity in July. So as I listed earlier about the aims, I'll hand over back to Peter to talk about the evaluation, which you'll be interested in, to see the impact and whether we have the processes and outputs in place to be on our way meeting those aims. So over to you. Thank you.
Thank you, Mia. That's a very helpful introduction into CWorks, and I'm here sort of to talk about the research side of it. So what we knew from conversations and what Mia has already outlined is that it's already having an impact across the region. So currently there's over 700 members signed up to the knowledge sharing platform, and over 300 resources have been uploaded, and membership ranges across the health system. So NHS itself, but also local authorities, voluntary sector, librarians, and various universities in the Northeast have signed up and are participating in this platform. And in doing so, as Mia already said, as it provides a resource for other networks to access the resources and questions posed on the platform. More internally, it enabled the public health knowledge and intelligence teams to be more policy focused in their output. So it helped them to really transform the way they disseminate their outputs to decision makers. And more wider afield, there's been interest from future NHS who are interested in scaling up this particular initiative, recognizing sort of the unique collaborative nature of it. So that's sort of initial impact that we were keen to progress. But also, we're trying to recognize the challenges, and that's sort of linked to the conference theme that we like to look at failures and successes. And some of the challenges faced in developing sort of an online knowledge sharing hub on this have been particularly around time and resources, particularly during a pandemic where lots of public health practitioners are very busy fighting the pandemic. Then developing a hub for knowledge sharing, how helpful it is. It comes on top of the day job, and that includes curating large volumes of online resources, but also brokering requests and knowledge out to the wider CWorks network. So questions raised to the example of Peter Kelly, and trying to sort of make sure that people pick up that question and respond. So connecting knowledge users and producers is sort of a key part of that brokering process. And then in developing the platform, be able to move quickly. Public Health England was able to make good use of an existing platform, K-Hub, and that provides a safe space because users have to register to access the platform. But that also creates some accessibility issues. Not all users are able to access the platform or find it tricky to sign in with their registration details. So there's a dilemma into creating a safe space and making it as accessible as possible. Another big sort of challenge is sort of the continual organizational change. I mean, nothing in the health system is certain, but change is always a certain. And particularly in these times of public health is changing in England and moving into a new National Institute of Health Protection. And in that, a lot of staff turnover is taking place, and trying to maintain a knowledge hub like this in all these organizational changes and staff turnover is an ongoing challenge. And last but not least, the team are having ongoing discussions about how to capture data about the ongoing development of the platform and the network and community. How do we capture user data and feedback? And partly that is tricky because of the platform it is hosted, as login details of the users on KUp as a platform, but not necessarily specific on CWorks as a platform within that. So that's something we'd like to look at in future development. And particularly the available monitoring data is really not sufficient to capture the impact that the platform is and the community is making. There is some anecdotal evidence of large sort of social activity outside the platform. So it really connects people up in sharing the knowledge, but we would like to be much better at documenting and demonstrating that. That's why we started the evaluation, and we're really at the start of this journey. And that comprises of 3 core components. One is around the process evaluation. So it's looking at key stakeholders' experiences of really developing and implementing CWorks as an online knowledge sharing hub. What are the key lessons, barriers, and facilitators, but also looking at the impact beyond the network. So interviewing the users of the platform and see what they've done with the knowledge that they access through the platform and where that ends up and how does it impact their decision making. So one thing we're keen to do is a social network analysis using an online survey with wider stakeholders to really map the reach and connectivity of the information that is accessed and the connections that are being made through CWorks, and then bring that together through joint implementation meetings to really look at the further development of the platform. So where we are now is that the research just started really, where we're interviewing stakeholders or starting the interviews with stakeholders and CWork users. And the idea is to feed those findings in sort of an action research methodology back to the CWorks management group on a regular basis through monthly meetings, because we really would like to develop this in a co-produced way by writing joint papers, also looking at joint funding applications for follow-up research in terms of the long-term impacts of developing these platforms, and capacity build as part of that in research skills in conducting evaluations among practitioners and policymakers. So one thing we're keen to do is develop a practical guidance document on really how to develop and maintain a regional knowledge sharing hub for practitioners during a pandemic, and then disseminate that through an event hosted by the ARC, the Applied Research Collaboration in Northeast of Cumbria, who has kindly funded this research. So a big thank you and plug for them here, but really then to have a ready set of people that are interested in taking this work further into a framework for a follow-up funding application. So we're at the start of the process. We're really excited and think there's much potential. And hopefully this is what your appetite a bit about what CWorks is and how it involves, but we're happy to take any questions, but I'll leave it here. Thank you very much for your attention.
Thank you very much, Peter and Mia. I think another great example of partnership. What we're going to do now is just to take a very short comfort break of 5 minutes. So it's right on 5 o'clock. We're running about 5 minutes late, but I think if we could ask everybody to come back by 5:05, please. A quick stretch of your legs, and then we'll come back to a presentation. Jane Powers, Mandy Pernington, and Heather Wickup-Beach are with us, but their presentation has been pre-recorded. So we'll have that ready to go as we come back in at 5:05. So enjoy a quick break. See you shortly. Welcome back, everybody. I make it exactly 5:05 here in the UK, and by the powers of Zoom, we're going back across the Atlantic to the beautiful campus of Cornell University at Ithaca, and I see there's a picture of it there just to show you how lovely it is. So the presentation that we're about to see is by Jane Powers, Mandy Pernington, and Heather Wickup-Beach, and they're from the Rothenbrenner Centre for Translational Research at Cornell. And I again will refer you to each of their bios on the website to get some more information about their previous work. So whenever we're ready, could we play this presentation, please? Thank you, Peter.
Good afternoon, everyone. Greetings from Cornell University here in Ithaca, New York. I am Jane Powers, the director of the Act for Youth project, and I'm here along with my colleagues, Mandy Pernington, director of our Research and Evaluation Unit, and Heather Wickup-Beach, who directs our training and technical assistant efforts. We will be briefly talking to you about our work with adolescent health providers in New York State and how our efforts to translate research were impacted by COVID-19. Our project is based within Cornell's Bronfenbrenner Center for Translational Research, which is home to multiple projects. All of us are involved in linking research and practice, bringing knowledge from the academy to those in the field, to educators, to frontline practitioners, and policymakers. We are honored that our center was named after Yuri Bronfenbrenner, a distinguished psychologist and member of the Cornell faculty. Yuri had a major impact on the field of psychology. Best known for his groundbreaking ecological system theory of human development, Yuri was doing translational research before the term existed. Our mission is to strengthen and speed the connection between cutting-edge research and the design, evaluation, and implementation of programs and policies that enhance human development, health, and well-being. Act for Youth is embedded within the Bronfenbrenner Center. Since its inception in 2000 with funding from the New York State Department of Health, Act for Youth has sought to promote the health and well-being of adolescents by connecting research to practice and applying knowledge about what works in prevention and youth development in communities across New York State. We provide training and technical assistance, conduct research and evaluation, and develop resources which assist practitioners do their work more effectively, and help policymakers to use research to develop initiatives and programs that promote adolescent health. For the past decade, much of our work has focused on adolescent pregnancy prevention initiatives. We work with over 65 organizations located in communities across New York State in metropolitan, urban, and rural areas. Since 2017, we have reached over 115,000 youth with our programming. All the grantees are mandated to use evidence-based sexual health programs, what we refer to as EBPs. Let me say a word about evidence-based programs, or EBPs. Over the past decade, the quantity and quality of evaluation research in the teen pregnancy prevention field has improved dramatically, and we have a strong body of evidence that programs can delay sexual activity, improve contraceptive use, and prevent teen pregnancy. Funders want to support programs that work. So what do? We have learned that you just can't give an EBP and expect people to be able to implement them. They need support. So we build capacity to use EBPs. We provide training and technical assistance and guide educators through the process of adapting the curricula in ways that don't compromise fidelity. We have learned from the field of implementation science. In order to achieve positive outcomes, we must implement EBPs with fidelity and quality. So we evaluate implementation and closely monitor fidelity, since it increases chances of program success and stronger benefits for participants. And we feed the data that we collect back to the educators through a continuous quality improvement process that aims to strengthen implementation and improve practice. Now I will turn it over to Heather, who will talk specifically about our training and TA and how we responded to the challenges posed by the pandemic.
Thank you, Jane. We're in a unique position working within these two overlapping realms of training educators to build their own capacity and training educators to deliver programming to young people. Before COVID, 90% of our trainings were in person. We trained on topic areas such as anatomy, puberty, and gender stereotypes, as well as curricula-specific training of educators, or TOEs. TOEs were generally 2 to 4 days long and ran from 9 a.m. to 4 p.m. each day. Participants not only learned the content contained in the curricula and the sequence of the modules, but the TOEs also allowed them to practice presenting by doing teachbacks in front of other educators. The other educators would role play the teens they could encounter in real life. After, they would receive feedback from the group to help refine their skills as facilitators. It was interactive, it was energetic, and it was really well received. So when COVID hit, not only did we have to find a way to do all of that in a virtual setting, but we had to lead and support organizations as they transitioned to a remote world as well. Like many others, Zoom became a part of our everyday language as a noun, verb, and adjective. As trainers, we were not only having to change the way we interacted with participants, but we also had to usher the participants through learning how to apply all of it into their own work. We couldn't just take the PowerPoints we used during in-person trainings and share them. We had to employ best practices in adult education, allowing them to share from their own experiences and keep it all active and relevant to their work. So how did we do it? We had to become creative and be willing to learn along the way. Remembering those adult education best practices would be even more important in the virtual world. Things like giving breaks every 50 minutes was a must. We had to be willing to engage educators in a variety of ways as well. We offered several webinars each week. These often were workshops that, if in person, would be a day in length. For the webinars, we would break down the content into 1-hour chunks over a few days. Learning communities were created around topic areas where they would come together and learn primarily from each other rather than just us. Our work groups were a space where we partnered with organizations and sometimes the developer and used our collective knowledge to take each activity in a curriculum and figure out how to adapt it into a virtual space. You'll see an example of one of these activities that came out of one of those groups in just a minute. We also offered a reading club that we decided early on would not require us to read a full book, but rather read articles and listen to podcasts suggested by participants in the team at Act for You. We would then meet as a larger group and discuss what we read or listened to and how we felt about it. This strategy in particular offered an opportunity to connect with one another on a more human level while still discussing relevant topics. It's important to add that we did our work with a trauma-informed lens. Using that lens, one strategy we employed was making sure we checked in at the start of each meeting or session. Checking in with participants, engaging how they were doing was important because we were acutely aware that we were in the midst of a collective trauma. And many of our program sites are located within New York City, where COVID hit particularly hard in the beginning. In order to help people be present in any session, we had to allow them to be honest with how they were feeling while using the time wisely. This is an example of one of the more fun scales we would use to take the temperature of the group. We probably utilized at least 25 different scales since the start of the pandemic. And on the days where a majority of the people reported they were feeling like the 2 in this picture, we made sure to add time in to let them share a little more if they chose to. There's no doubt that personal and professional lives were intertwined at some point for all of us. We saw each other's homes and loved ones, listened as people shared losses, and extended empathy to each other as layoffs began for some organizations. Becoming a safe space for educators meant they were more likely to come back and be more engaged in the process as a whole. Creating a safe space to make mistakes was equally as important. For people who have not spent much time in a virtual space, it was a terrifying world to be in at first. They knew the content inside out, and it was the new teaching territory that was foreign. These are screenshots from a learning community meeting early in the pandemic. We'd asked participants to share the challenges and successes they've experienced during virtual sessions. You can see under difficult, confidence in using new features and online tools is one of the challenges. In response, we not only brought in people, many times their peers, with some more expertise in different platforms, but we also offered practice sessions where educators and supervisors could practice things like creating breakout rooms and sharing screens and videos. Learning the basics helped them build confidence in their ability to engage young people virtually. Most EBPs utilize several different teaching strategies throughout their curriculum to coincide with different learning styles. Brainstorming is used to assess knowledge of the group and stimulate discussion. Modeling and demonstrating uses visuals to accentuate learning and illustrate proper procedures and techniques. The most common example in our work is the condom demonstration. Short lectures are the more traditional way of facilitating content. Group processing is done in conjunction with other strategies to build group cohesion and encourage critical thinking. Videos are used to introduce information at an appropriate level to the group, and most often includes characters and situations that young people easily relate to. Interactive games, again, reinforce content knowledge in a fun and interactive way. And role plays develop interpersonal and problem-solving skills and give the young people a chance to practice and develop positive behaviors. But none of these were designed to be done in an online classroom. So we had to take all of these strategies and translate them for the virtual world. I don't have enough time to share examples of each, but I will share one. Role plays were one of the most difficult teaching strategies to translate into the virtual world, not only because of the lack of in-person interaction that is inherently associated with the strategy, because traditionally this is also the least favorite strategy among educators. Pixton is a website where a teacher can set up a classroom and invite students to it. Students can then create their own avatars and make storyboards and comic strips. The direction an educator gives for the role play in Pixton is almost exactly the same as when they are in person, except when you assign a scenario, the role play is done by the avatars. When they finish, the students can read the dialogue out loud and get feedback from the rest of the group, just as they would in the classroom. Using something like Pixton, we're able to maintain the goals and objectives of the intervention while adjusting to the rules of living in a pandemic. Now I'm going to turn it over to our Director of Research, Mandy Purrington.
Thanks, Heather. So we've shared a bit about how our work has pivoted to support educators during this pandemic. And the efforts seem to be working well in practice. That is, educators and youth are engaged using these new strategies and techniques. But this is anecdotal, and we have outstanding research and evaluation questions. We need to build the evidence here. One of the questions that we face is, how successful are we in actually building educators' capacity to implement the EVPs in these virtual settings? Another question is, how do variations in implementation affect youth outcomes? And really the big question here is, what is the impact of virtual implementation on youth? Much of our efforts recently have been focused on helping organizations and educators implement in these virtual settings, and we hope to be able to turn to these outstanding research questions next. So on behalf of Jane, Heather, and ACT for Youth, I want to say thank you for your time and attention today.
So thank you for that really clear presentation and an excellent example of how we can adapt good practice and real imagination as to how you've made that happen. I love the avatars, so we'll all be thinking about creating our own avatars for our next meeting. So I think we're on to our final presentation now, and it's a real pleasure for me to welcome Roland Ball, and we're now heading back to Europe, and we're in the Netherlands, Roland is the Professor of Healthcare Governance at Erasmus University in Rotterdam. And Roland, like Jane Powers, are members of our external advisory group. They're international members for our FUSE Advisory Board. And we're very honoured to have both of them join that board and share their knowledge and expertise. And Roland's going to do just that this afternoon. So over to you, Roland.
Thank you. So welcome to you all. Good afternoon. It's actually evening has started here just about 50 minutes ago. What I'm going to do is a little bit different from the other talks because I'll be talking a little bit from the receiving end of knowledge also, although we will see that it's also a lot of production going on there as well. I called my talk Relational Knowledge Practices in COVID Decision Making. And what I want to show actually in the talk is a little bit how knowledge practices in crisis situations like COVID are very much relational, and how are they, and that they are taking all different kinds of things into account. I have to, yes. I'll start with a quote from a doctor in a hospital, in a university hospital, who we've been following, saying during that weekend, which was end of February 2020, a colleague from Italy called me saying, it's much worse than you think, so please start in time. And actually by then, the hospital had already started what would soon be a sort of roller coaster management of the crisis, with lots of uncertainties, many things that they had to decide on the spot, evaluate, make new decisions, and so forth and so on. And those uncertainties, sort of pandemic uncertainties, were not only cognitive or were not only medical. Actually, they were spread across many different areas. Yes, there were medical uncertainties. How does the virus spread? How does the disease develop? All those kinds of things. There were microbiological uncertainties. How can we best protect ourselves, employees, patients, visitors? But there were also a lot of ethical uncertainties. For example, who needs protection? Who needs treatment? How to deal with non-COVID care? There were behavioral ones. How will patients, employees, citizens react actually to what we're doing? There were institutional ones, how to organize decision-making during the pandemic. How does the crisis organization relate to normal routines? And there were political ones. Any decision that we'll make will be evaluated later on. How can we get support for what we're doing? In my talk, I will talk a little bit about sort of how those uncertainties unfolded during the decision-making, both on a local, a regional, and a national level, and what kinds of strategies actually the actors used to deal with those kinds of uncertainties. I will base that. We've been very lucky. I was in a meeting early March 2020, when the first, actually just before the first patient arrived, and the dean of the medical faculty was there, and I talked to him and I said, you know, we want to be there because this is going to be huge. And 2 days later, we were there at 8 o'clock in the morning during their crisis, in their crisis management team, and we've been there for a couple of months, and then heading on to sort of the regional and also the national level, which we've been studying since then, or sort of ethnographically following. We also did loads of interviews with professionals in the hospitals, with patient representatives, with national actors, etc., and studied tons of policy reports. Actually, you can imagine there's so much data that we are in the middle of analyzing and sort of going along with that, doing a sort of what we call an abductive analysis, in the sense that it's very bottom up. We didn't get in with a specific question. We just, you know, were there observing, and then talked a lot amongst a group of researchers. Okay, what are we seeing? How can we make sense of that? What is the next step in the data collection and in the analysis? So this is the team of people. We've been with 7, doing the interviews, doing observations, and reading stuff. The first thing, of course, is that, you know, when the first patients arrived, there was a lot of medical and microbiological knowledge that was lacking, and you can sense in a way sort of existential uncertainty. What is happening here? And there was lots of things that needed to be sorted out, and you can see on the one hand that there were lots of sort of formal structures like the outbreak management team that helped in doing that. So people met online or still in rooms by then also, or on the phone, in these sort of formal meetings where they discussed what is going on, what do we know, the international knowledge, the local knowledge. So Jaap van Dissel, for example, he's a chief epidemiologist of the Netherlands. So they have lots of data about, all kinds of virus-related things. Marion Koopman, she's a virologist also in the hospital that we were studying, she was, for example, part of the WHO team that went to China, and so has lots of contacts at WHO, etc. And you can see those kinds of sessions as a way of, trying to make sense of what's going on. And these happened both in sort of the formal structures, like the outbreak management team. They also happened a lot in all kinds of informal meetings. So telephone calls, WhatsApp groups, people discussing all the time, in evening meetings and during the day. Everything actually they were doing, in a sense, was trying to create a sort of collective sense of what is going on. They were gathering numbers, they were gathering perspectives, they were doing lab research, they were studying literature, and every sort of practice you can imagine, everything that they could do, sort of to get bits of knowledge together to start developing a policy of what to do. There was also a lot of anticipation going on, and one of the things that was that struck in the pandemic was the lack of materials, and actually the lack of everything. So masks were, very famous for being short. You can see a picture here of actually the head of the hospital and the people from the ministry with boxes of masks that were just imported from China. Actually, the boxes, when opened, the masks didn't fit European heads. So they had to, tinker their way to make the masks work. At one point, they actually sent a model of a European head to China, to make fitting masks. But everything actually was lacking. And you can see here also, this is a purchaser at the hospital talking about suction equipment. It's impossible to get right now. We plan to use them longer. The ones we used normally 24 hours, or this should be 48. The ones 72 in use will until they get clocked. And the microbiologist responding in a sort of way that is, understanding this has to be done, but on the same way, on the same level, this creates another uncertainty, right? Because we're lowering quality standards, so we can expect sometimes to have to account for that. And so this has to go on the list for the inspectorate. And actually, that was a very long list because of many things that sort of needed to be done during the pandemic that was not done in normal situations. The other picture is showing a protocol, and one of the things that we found during our observations is that protocols were very important. But you can see that, so this is a static picture, and actually it changed almost every day. So the protocols were changed every day on a regular basis, at least, based on new knowledge, based on what we knew about, what to do, based also on what was there, what kind of equipment is there, can we still use them or not, but also based on how do we know that how people are reacting. So the microbiologist team actually in the hospital was running around the hospital all the time to see how people reacted on the floor. To see how nurses were doing, how doctors were doing, how patients were doing, how visitors were doing, and to respond to that in the protocols as well. So there is a sort of practice of writing the protocol and then rewriting it in a very sort of iterative and reflexive manner. As I said, there were also lots of sort of ethical issues going on. So whom to protect was a very important question. And here is an observation in the local outbreak management team. saying we have a meeting with the hospitals in the region shortly. They want to have a uniform policy for visitors, but some of them don't allow visitors at all. We will not follow suit. They will have to accept that. So this hospital was still accepting visitors. They had enough or they also made a choice to use some of the protective equipment to allow visitors one a day for each patient into the hospital, but others didn't have the possibilities or have the policy not to do that. And again, this created uncertainties in the sense that there was some sort of regional, maybe lack of solidarity, or at least a need for a regional consensus about what to do. So how to create such a consensus was very much a topic of talk all the time, and talking to the other hospitals, trying to create a sort of, shared policy or not, was one of the things that was going on. One of the groups that were very important in the hospital were the cleaners, and actually all hospitals were struggling with the cleaners. And again, there was a sort of discussion going on all the time about how to protect the cleaners. And some hospitals were actually giving them the FFP2 masks to the cleaners, but our hospital decided not to. But again, in a sort of constant struggle with the cleaners, because you want to keep them, friendly. You don't want them to run away, being scared. One of the things that happened during the pandemic is that new structures were set up. So in the Netherlands, one of those structures was the National Patient Spread Organization, and that actually was a national organization handled mostly by the hospitals themselves, but with help from the military, with help also from research organizations, that was collecting data about COVID patients, how many patients are in the hospital, how many patients are in the ICUs, what is the capacity in the local in the different hospitals, and then organizing a sort of distribution of patients throughout the country. So this is a picture of the bus that they had, but of course there were many ambulances. The bus came very handy, at least in the beginning of the pandemic, and it could they could put six patients in it and then travel, through different places. But counting beds, as simple as it might seem, is not as simple as that. So, for example, there had to be a definition of what a bed is. It might be very clear. Where a bed is a thing where you can lie on, it has a mattress and all those kinds of things, but it's not as simple as that. So a bed is a bed plus personnel plus equipment. And so it's very sort of local knowledge about how many beds do you have. What the capacity is even more local knowledge, because it would mean that you would need to know, okay, what is normal care going on? What kind of how many beds do we have? How many beds are we going to need during the day to actually make sure that, say, some necessary operations will still be able to go on. We expect, still a lot of or some of the COVID patients who are in the clinic to go to the ICU, all those kinds of things. And so one of the things that happened is that hospitals actually sort of had buffers. And this is the quote saying, let me give you, so this is someone at the National Center talking, let me give an example of the ICU. Regions report how many capacity they have, but hospitals argue like this. I have X beds and Y are taken partly by COVID patients. That leaves Z beds, say 5, but they only report 2, so they create a buffer. But at the regional level, they also create a buffer, so they have some leeway. And then it comes to us, the National Patient Spread Organization, and we say, shh, but then we can no longer spread. But that's not true because of all of the buffers in the system. So there is this sort of informal knowledge. There's actually more room to spread patients, but formally there is not. So in the backstage of this sort of formalized system, there is a lot of telephone calls all the time going on to see if hospitals do have room still to take some patients. Okay, some reflections, and actually, I just took a couple of examples, and you can understand there's many more. Some reflections still. So the pandemic comes with many uncertainties. That's clear, right? There is a lack of knowledge, lack of scientific knowledge. How is the virus responding? How is it spread? How does the disease develop? All those kinds of things. But this actually is only a very small part of the uncertainties that people at the work floor, at the sort of decision-making tables are confronted with. One of the others is that existing structures and routines no longer work. So they have to build up new routines, new structures to actually create, not only to get the knowledge that they need, but also to make the decisions and to get support for those kinds of decisions. Because also emotions and politics play a large part in that. So I've listed some strategies to deal with that uncertainty. And of course, research and exchange of experiences are very much part of that. And we can see also the huge importance of informal contacts between decision makers, between researchers and decision makers, between actually different, but also sort of collecting knowledge on the ground floor. We can also see a lot of mundane work. So counting and supply management were crucial. How many beds are there? How many masks do we still have? A lot of tinkering is going on as well, experimenting with, can we reuse masks? Can we make them fit into the heads? And also a lot of writing and rewriting of protocols. Fourth, relational work is very important in this sort of managing uncertainty. So both on a local level within the hospital, but also between hospitals and on the national level, and actually sort of constantly going back and forth between those different levels. And last, actually, the sort of creation of new coordination structures. But the structures never do the work themselves. So they have to get supported again by sort of informal work in creating knowledge and in getting there. And so this is the sort of what I mean with this notion of relational epistemology. So the importance of informal context, but also the collective sense making that's going on. It also has consequences because, as I said, many of the contexts actually were either, some went through formal procedures, but a lot of that went through informal work. And that also meant that some voices just don't get heard so much. The voices who are not in the informal networks. So workplace experiences are not systematically explored. Actually, we know that nurses were playing a very important role in the hospitals, but their voices were not heard all the time, at least by the boards or the decision makings. Patient experiences were largely left out of the picture. So that is a thing around long COVID, for example, and the emergence of long COVID through the patient organizations that is now being taken seriously, but it took quite a while for that to sort of surface. And thirdly, the objective status of numbers goes largely unquestioned. We've been bombarded by numbers every day. We still are actually, I don't know how that is in your country, but we still get the amount of positively tested patients each day on our phones, the amount of patients that are in a hospital, but we know that there is a backstage to that, to those kinds of numbers, and people inside the system actually know that and know how to deal with that, but people outside take those in a very much more objective way. So this also calls, in a sense, for the broader knowledge platforms, for creating spaces where reflection with different actors can actually be organized. And I think at least what we've seen in the Netherlands is that it's very hard to create those kinds of spaces and to get a sort of word for, well, the experiences of the unheard. Okay, so thank you. for listening to, for bearing up with me. These are some of the thank yous also for the people who've made this possible.
Okay, thank you very much, Roland. And I think we've got now a short time for some questions. So I'm going to ask the speakers all to turn on their cameras. We've got some questions in the chat, which I'm going to try and field and ask Peter also to help me with some of those. And while you're all gathering your questions, I think I would like to thank all of the speakers. And we've had some excellent examples of carrying out research at pace, and staggering, looking at the extent of misinformation and how that from a minute number of primary sources had a massive dissemination and the impact of that. Ensuring policymakers have evidence to be able to make good decisions in what has been an incredibly rapid moving environment from all aspects, and also adaptability, how we take the best of practice to take it online, and then that action-based research where Roland is actually in there, in the thick of it, and watching what's going on and what we can learn from that. So I think one of the questions about, what can we learn from this for the future is one I'd like the panel to address. I guess maybe each of you could just, in the first instance, then we'll come to some of the questions from your experiences that some of you've outlined. What do you think would be your sort of takeaway learning from what you've experienced over the last 18 months plus? So maybe we'll just go around the speakers in turn from that. Peter, what would you say that everybody was fascinated by your presentation? I know you weren't here when we were playing that, but I think struck by that very, very small amount of primary information and how it was spread. What would you say was your main learning from this period?
Well, I guess for me, what I'm struck by is the disconjugate nature of what science has produced and the way in which science is discussed. I mean, this pandemic could be considered to be a triumph of science, right? In that people have done studies, they've generated data, they've developed treatments, they've developed vaccines. Yes, there have been some mistakes. Obviously, science evolves at its own pace. But what we've learned is that science, like all other kinds of information in contemporary society, or at least particularly in the United States, is defined by ideology, and people seem to have their own science the way they previously had their own facts, and before that had their own politics. And that aspect of it is just incredibly disconcerting. I spent a little bit of this morning on a television program talking about ivermectin, which I don't know how widely used in Europe it is, but it's used widely in the United States, primarily by horses. But it's now suddenly turned into a treatment for people on the right who are worried about COVID. So we now have our own separate science, we have our own separate ideology, we have our own separate treatments. And the real task at the end of the day is going to be to bring everybody back together.
And it's certainly a challenge laid there, Peter. I wonder if perhaps Maureen or Leanne would like to make a comment about what their main learning has been.
Well, I'll comment and then invite Leanne as well to comment. There's been like a great deal of learnings for us, but I think the ones that come to top of mind for me was pre-existing long-standing relationships with the public health sector in Canada. So I've spent my entire career working collaboratively with public health at all levels to support evidence-informed decision-making. And so early in the pandemic, they then were turning to us for help. At first, it seemed like it might be at the more local level, to support them in doing their own evidence syntheses, but then that quickly transitioned to no one would have time to do that. So was this something we could do? And that coincided with me having long-term funding for a center through to 2028. I actually had just been refunded April 2020 through to 2028, and my funder, the Public Health Agency of Canada, saying to myself and my the five sister organizations, there are 6 of us, saying that we had the flexibility to use our funding in whatever way we could to support decision making and the public health sector. So having that flexibility to basically put aside what was in our accepted work plans and then use it how we saw fit, that allowed us to then pretty much pivot probably 2/3, if not more, of our funding towards the evidence syntheses. And then the final comment I'll just make is around flexibility. So as we've heard today, I mean, nothing has stayed the same during COVID. Things, even in the evidence ecosystem, the availability of evidence, the types of designs was changing on a daily basis. And so the methods for synthesizing the evidence needed to change to coincide with that. So the flexibility to be thinking about the highest levels of rigor that are feasible within this constantly changing environment. And, you know, many academics, particularly in the quantitative world, would have a fair amount of discomfort with constantly moving methodology. But that was really important. To every couple of weeks, it seemed we needed to stop, pause, and think what is relevant now, given what we know.
Yeah.
Leanne, over to you.
Thanks, Marina. And Leanne, anything to add to that?
Great, thanks, Marina and Ashley. I think the amazing thing for me has really been the public awareness of public health that wasn't there before. 2 years ago, I think most people didn't even know what public health was. And now everybody knows what public health is and what we do and the importance of public health research. And that there has been this increased interest in evidence-based public health and research. And we can see that even through my organization, I work for Appraisal organization, the Public Health Agency of Canada, we've doubled in size in the last 2 years because the public and government has realized how important public health is for a country, and we're not planning on downsizing, which is wonderful.
And also you were gathering the evidence for the decision makers at the time that they needed it at great pace. Mm-hmm. So that ability to flex, as you've referred to there, Maureen, was paramount. Peter or Maya, do you want to just make a brief comment about your learnings?
I'll let Maya answer that one.
Well, I was just thinking on the line of collaboration. I think what the pandemic and in working life, but also my street, once there is a common goal, working together becomes much easier to facilitate. We recognize that we all have the same interests at heart. Different partners wanting to reduce health inequalities at a regional level. Actually, it's very easy and people are very keen to work together. And I sort of knew that before, but it has highlighted it's not actually that hard if we have recognition that we're all in it together, whether it's people on my street or in working life. I think that would be my takeaway and be very positive today.
Thank you. That's very positive. There was somebody made a comment about there's no way we're going back into our silos. So let's hope that's the case and we can continue the relationships that have been developed that have been so beneficial. Jane, do you want to, Mandy or Heather, just maybe comment on how you were able to adapt in that circumstance and what perhaps there was a question in the chat about what worked best in terms of using those platforms that you might not go back to what you were doing before.
I think I can jump in and answer some of the first part of that question, but really I think our big learnings and reflections on this are similar to what others have already said. I would say some of the big themes for us have been the need for flexibility and also how important collaboration is. So, you know, in the work that we've been doing with educators, working with young people, just this need to kind of be flexible in our approaches, assess kind of very quickly what seems to be working or not, and then adapt and, you know, just kind of continually being flexible and adapting what we're doing. And then the collaboration piece, this is kind of across stakeholder groups, you know, so we work very closely with the State Department of Health here. So everyone from policymakers who are really definitely dealing with the response to COVID and have many different kind of demands and pulls on their time, to the educators who are, you know, trying to reach and engage young people in new ways. It's been very important to have all of those stakeholders at the table.
Great, thank you, Amanda. Just check your co-speakers want to add anything else to it, or has Amanda said it all?
I was just going to add to answer the question that was in the chat box around this different strategies. You know, they all took different. It took different ways for each of them to really translate. I think the thing that surprised us was with the videos piece of it. We had to make the videos shorter because all of a sudden, you know, students weren't in the classroom anymore, right? So when our educators would go in the classroom and they'd share a video, it was a novelty, right? It was something fun, it was something new. And now all of our young people have been sitting in front of a screen all day long for all of their classes, and those videos were not nearly as fun as they used to be. So that was definitely one of the things that was a takeaway, and that was something surprising. But again, like many others said, just always pivoting, always kind of just working with what we had. I know in the beginning, a lot of people really insisted that young people share their screens, right? Like that's how you're going to make sure they're engaged. But we know that that's not a very trauma-informed way of doing things. And so we went to different ways of how are they engaging? How do we know that they're engaged without re-traumatizing all of these young people? So there were a lot, and I could go on for another 15 minutes.
I was struck by this the level of support you were able to offer people across all of those platforms. Jane, do you want to say anything? No, you're good. Roland, is there anything you want to add to that? And then we'll take some further questions from the chat.
Yeah, so I think, well, in a sense, so our research actually sort of confirms what the others have been saying, that you can see that there is a lot of collaboration going on, and there's a real change also in the way that policy is being made and who is involved. So the buildup of those informal networks that I've been talking about, and also new formal structures, and they are not easily to get rid of. So so these new structures are, it will still be, there is a lot of uncertainty, of course, you know, what will happen in the future and if things actually do stay. But I think, for example, areas like public health will get more attention in the future, etc. As to us, so responding actually to one of the questions, so what we've been doing is, so as ethnographers, we sort of, you know, hang around, right? This is what we do, and just listening in and sort of having informal chats with people. But we've also been very much reflecting with the actors about, you know, sort of the things that we saw and also the things that we sort of didn't see. So who is not there in the room? What kind of knowledge did not get onto the table? And that, in a sense, I think. Or, you know, and talking also with them about their own blind spots. So, for example, one of the blind spots that we were talking about very early on was sort of non-COVID care, or, you know, regular care. Where are all the cardiology patients? Where are all those? So, and then they started setting up sort of networks also with GPs to reach out to sort of the regular patients. And so there has been a lot of reflection, I think, that we've been trying to, you know, stimulate with them. And of course, yeah, so.
Yes, it's all of those people that now are on those wait lists that now need it to be seen. Peter, I'm just going to come to you. You've been looking at the chat and whether there's anything. People have answered questions if we've gone round. We've got just a few more minutes, and I know people will need to leave. And I want to thank everybody before that happens. Any questions in that chat that we haven't answered?
Yes, there's a few questions. I will try to highlight them, and if there's not enough time, then maybe we can answer them afterwards or send them to the speaker so they can respond. But there's a question for Leanne and Maureen in the chat, and it says, you identified a range of quality issues with primary research. Is there a place for improving evidence generators' knowledge and understanding of the needs and expectations of evidence synthesizers, and what might that look like in practice?
Yeah, that's a really hard question. I've been grappling with that. I liked actually question 2 better, but
feel free to think of question 2.
I think that idea there. I mean, there are many tools, checklists that exist for appraising the quality of many different types of designs that evidence synthesizers will use. So I think the evidence generators, so those doing generating primary research, if they were aware of the types of criteria that are used to evaluate different types of designs and having that in mind when they are developing their studies, that certainly would help. And even knowing what constitutes good evidence synthesis, which requires an appraisal of the literature, might help as well for the evidence generator. And just part 2 of that question in terms of, this idea of the rapid review methodology moving forward post-COVID. I mean, I certainly think that we're not going back, like we've heard that for other things. I would be surprised that decision makers, policymakers would go back to a situation where they're being told they need to wait 2 years for that review, systematic review, to be done. But a significant challenge will be the magnitude of evidence that needs to be synthesized in different areas. For example, chronic disease prevention, of which there is significantly more research than exists for COVID on multiple topics. So that was part of what made it easier early on, is that there was lots to sift through, but there were relatively few studies. So we have to think really carefully about how to do that. But I certainly think we need to be thinking about how we're going to do it if we're going to keep policymakers and decision makers engaged in using that evidence.
Thank you, Maureen. Peter, I'm going to squeeze in one more question with one brief answer, and then we'll close.
Okay. So. This is a question for Roland, and it's the question is: could you please reflect on the extent to which the knowledge that was at the time being produced by evidence-based medicine scholars actually aligned with the knowledge needs from, say, hospital administrators? Okay,
and Roland, you have about 30 seconds.
Yeah. Yeah.
Challenge.
Now, well, the thing is, of course, I think I think in a way, yes, although it's also difficult to answer because there's because of all the different values and valuations that are going on, right? So it's not just that one sort of piece of knowledge fits into a question. There's many different sort of considerations to be taken into account, and then yes, of course, you take that piece of knowledge with you, but there is lots of conflicting evidence all the time. There is lots of different disciplines coming in that may say different things. So I do think that in the end, sort of the collective sense making and the collective decision making is very important, to get all these pieces together and sort of to make sense of it, rather than saying, well, this piece is going to sort of define what is actually at stake.
And I guess out of that is the learning for how that can be improved and done better in the future. And I think that capturing that learning from this, and what I've heard is we're not going back. And we here today we've been able to go around the pretty well, not around the globe, but certainly across continents, backwards and forwards. And thank you all very much for your engagement and for the speakers. I'm just going to ask Peter to put a couple of closing slides, just so you can we can make sure that you know what's coming up. So this is just some online events coming soon across Fuse, and please do visit our website for that. I think I want to make sure that we've thanked everybody before we go into that final slide. So I just want to thank all of our speakers, the organisers for this meeting, and the planning for the international conference. And there's a lot of work going into that, and I very much hope that we'll see you all in Newcastle in June of next year. And we are looking at options of how we would be able to combine the best of what we've learned in terms of they have been online, but also getting the best of also being able to see people in person and build our networks further. It's been a fantastic 2 hours. I've very much enjoyed listening to everybody's presentations. Huge thanks to all of our speakers. Please note that where this is. Do tweet afterwards if you wish, and we'll follow up after this in terms of how we were able to share from this conference. Just going to check with Peter. I haven't missed anything.
No, perfectly done. We will share presentations and recording, but otherwise, a big thank you.
Okay, so thank you very much to everybody, and enjoy the rest of your days, nights, evenings, and whatever remains of your day. Thank you very much indeed. Thanks. Bye-bye.
Thank you very much for joining. Take care.